when it's done and ready, please, I will send it around. I will send a link around with Jeannie's permission. And if you haven't got it, just email me and I will forward you the link. I will now mute everyone. And if you have any questions, we'll leave a few minutes at the end for questions for Jeannie. If you have any questions, please type it on the chat page so that everyone can see it and Jeannie can respond when she's done with the talk. Because there's so many people online, could I also ask you please to turn off your video in case the Wi-Fi gods get unhappy with us and decide to cut us off. If we do cut off at any time, I will reconnect up, but hopefully we don't have to do that. So without further ado, thank you so much, Jeannie, and the show's yours. Thank you.
Thanks, Julie, and thanks for the invitation to be part of this seminar series. So thanks everyone for dialing in. It's wonderful to see so much interest in long-term outcomes, which is a passion of mine. So I am a neonatologist. I work in the neonatal intensive care unit at the Women's in Melbourne. But for quite some time now, I have developed a very healthy interest in understanding what happens after the babies go home. Of course, initially in childhood, but as time has gone past, you know, they've grown up, they become adolescents, and now they are young adults. And which is really the topic of today's talk, preterm children, what happens to them when they grow up. Now, many of you who work with preterm newborns would have probably been asked this question at some point in your career. You can see around this page lots of photos of babies having respiratory support. The one in the corner is a very old film of a baby with a head box. Hopefully, you know, we don't use that too much anymore. But it's just to really illustrate that, you know, we've had quite a few decades now where care has been so good and that we've been able to see improved survival rates to the point where more and more of these vulnerable babies are becoming young adults. So many a time I do get asked by the families I look after, what will happen to my baby when he or she grows up? Will they go to school? Will they get a job? Will they partner and have children of their own? So I'll touch on some of those topics today because there has been a fair bit of research in this area, but only to grow as we get more and more survivors getting older. I don't know how many of you read this very recent news report published in Nature. So the journal Nature actually has a news section. And Amber Dance, you see here, she's a scientific journalist, contacted quite a few people around the world who have an interest in adult outcomes of preterm-born children. And both Lex Doyle, my mentor, and the guru of long-term follow-up and myself were fortunate enough to be part of this article. And this is the title, Survivors of the Littlest. It is a very heartwarming article. For those of you who have not read it, I'll be very happy to share the link with Julie. I really encourage you to read it because it gives us hope. And the quote up here, this is an exciting time for us to really make a difference to their health. And this applies to every single one of us involved in the care of the preterm newborn. So you ask, well, why bother about adult outcomes? Why are they important now? Why were they not important 20 years ago? I'll show you this graph of survival rates in Victoria in Australia. The trends will be similar worldwide, although the time frames might be different depending on when innovations of care were introduced in your country. So for us, as you can see here, survival rates were really less than 10% prior to the 1970s. They started to go up in the 80s, and you can see here a significant rise during this period, and they have continued to stay fairly high and gradually creep up. Why? In Victoria, we certainly rolled out antenatal corticosteroids to the pregnant woman at risk of preterm birth around that time. We then had exogenous surfactant to treat respiratory distress syndrome in the preterm newborn, and that really helped us a great deal. Around this time, of course, there was increased willingness amongst healthcare professionals to offer intensive care, to offer resuscitation and respiratory support to these babies, because we know that without that, they will almost certainly not survive. And so now, as a result, if you do the math, more of this increased survival, they're getting into young adulthood. They're getting into their 20s and their 30s in larger numbers than ever before. When we think about outcomes and we're counseling parents, you can see on the left here, I've got a whole range of things that we usually talk about. We talk about survival, we talk about cerebral palsy, neurodevelopmental problems like blindness, deafness, delay. And if we dare think beyond the early childhood period, we do even touch about school and talk about academic performance. But life doesn't just stop at school. As many of us will know, it extends well before that, beyond that, and therefore we need to understand what the outcomes are beyond childhood, because these individuals are now living to adult life. So for today, I'd like to cover some of these areas. Now, I do apologize, I can't do that in great detail in 1 hour, but I'd like to touch a little bit about cardiometabolic health and the various components of that: lung health, mental health, quality of life, and adult functioning, things that really are important as you transition to adult life. Of course, neurodevelopment and disability remain important, but I've got it grayed out today because there's so much more written and lectured about that, that I've chosen not to touch on that today. So firstly, let's talk about cardiometabolic health. Why am I interested? Why are we interested? Now, for those of you who will remember, there is the famous hypothesis postulated by David Barker in the early 1990s. Now, David Barker is a famous English epidemiologist and wrote the book Fetal and Infant Origins of Adult Disease, the DOHAD. And in that is a quote that intrauterine growth retardation, low birth weight, and premature birth have a causal relationship to the development of hypertension, coronary heart disease, non-insulin dependent diabetes in middle age. This quote rings very true when we think about what the potential morbidities are that are faced by these preterm survivors. So, is David Barker correct? Well, let's have a look. There are many research groups around the world, including ours, who have reported on the growth and body composition outcomes of extremely preterm survivors. We know that extremely preterm babies are usually shorter and lighter than their term-born counterparts. But we know also with increasing age that the height disadvantage persists, so they are still shorter, but you do see a catch-up in weight and body mass index. And this is potentially not advantageous when you think about growth and body composition. There are studies that have reported lower lean body mass. Now, lean body mass is the good body mass, and studies have shown that extremely preterm adolescents and young adults have lower lean body mass than their term controls. And there are also studies that have documented that there is increased central adiposity, which is also an unfavorable distribution of fat. So there's already reports that would suggest that preterm young adults have got a more disadvantageous growth and body composition that may put them at higher risk later on. Now, Julie mentioned Vix, so I'll spend a slide or two explaining to you about our program. The Vix Collaboration, it stands for the Victorian Infant Collaborative Study, and it's a collaboration of all the tertiary neonatal intensive care units in the state of Victoria in Australia, as you can see here, 4 of them. Our care is centralized, and so all extremely preterm, extremely low birth weights are cared for in one of these 4 units. Since the late 1970s, Vix has been a program of research where we have recruited prospective cohorts, and you see here the multiple cohorts. We have 6. The latest one was in 2016 and 17, and watch out for the 2-year outcomes, which we are very actively analyzing and hope to publish in the next 6 to 12 months. But it's a series of cohorts recruited at birth with term controls. We've tried to get everyone in the state, so it's epidemiologically a very strong study design with contemporaneous controls who we have seen at various ages, but usually at 2, 5, 8, 18, and 25 years. There are a few studies from the 91-92 cohort who are now, of course, in their late 20s, who were seen at 25, which I will refer to in this talk. You'll just see here, this is a map of Australia. New South Wales is where Julie is. Here we are, Little Victoria in the corner, but a quarter of all Australia's births actually come from this small little red bit. The Vix group did look at growth in our survivors from the 91-92 cohort from birth to 18 years. We had 166 extreme preterms and 153 controls, with measures of weight, height, and body mass index at these various ages that you see. So not only were we able to compare with controls, we were also able to track to see the trend as these individuals grew up. I will summarize the results of that study in the next 3 slides. So firstly, weight. The results are presented as Z-scores because it takes into account their gestation, corrected gestation, and their sex. And you will see here on the y-axis Z-score. A Z-score of 0, think of it as average. Anything greater than 0 is sort of higher, and anything lower than 0, of course, is a lower Z-score, a lighter weight. You see here the term controls in the orange line and the extreme preterms in blue. So what did we find at birth, hospital discharge, 2, 5, 8, and 18 years? Well, the biggest disparity was seen at discharge. This is not surprising. We really struggle to get extremely preterm infants to grow very well in the neonatal nursery, despite all the things we pump into them, and that's certainly an area that we need to improve on. But as they grow up, you can see that that gap becomes narrower. And those of you who were awake will remember that I said we saw them at 25. The data is not yet published, but I can tell you that that gap is even narrower at 25. How about height? Same layout, a Z-score here with 0 here, meaning average. So you can see the term controls were above average in their length and their height as they grew up, but the extreme preterms were lower than average. And really the gap is unchanged. They're still shorter than the term counterparts. But how about body mass index? Body mass index is a calculation based on weight and height. And as you can see here, once again, with the term controls and the extreme preterms and 0 being average, the term controls are near 0 when they are 2, and they gradually rise as they get older. So, you know, is this the obesity revolution that we are seeing? I mean, who knows? But interestingly here, and worryingly so, the extreme preterms who start off lower than their term counterparts have already caught up by the time they are 18. So this is not an encouraging trend. Their BMIs have gone up, and what you wonder is as they get older, will they overtake their term counterparts? We wait to see. The next aspect of cardiometabolic health is blood pressure. Now, we know that worldwide, certainly in the sort of middle to high income countries, cardiovascular disease is one of the most important and main causes of mortality, up to 30% in the high income countries. High blood pressure is one of the most important risk factors. And we've known for a very long time now that for every 2 millimeter increase in diastolic blood pressure, we have a jump in all these mortalities of hypertension, coronary artery disease, stroke, or transient ischemic attacks. So 2 millimeter increase is a very clinically important change. I want you to keep that in mind as I go through some of the results slides in a minute. And we know that extreme prematurity is associated with higher blood pressure in many studies across different populations. So this is a risk. A few years back, a collaboration known as the Adults Born Preterm International Collaboration. So these are guys who are interested in adult outcomes, and certainly we in Victoria are part of this collaboration. They pulled together data from all their cohorts from around the world and reported this individual participant data meta-analysis in the journal Hypertension back in 2016. They had 9 cohorts, over 1,500 very low birth weight, very preterm adults, and 777 controls. The mean gestational age of the combined cohort was 29 weeks, and the age at blood pressure measurement ranged from 16 to 24 years. And what did they find? What they found is what we had known before, that very low birth weight individuals have higher systolic and higher diastolic blood pressure compared with controls. So it's summarized here. You see on the y-axis is the mean difference in blood pressure. So this is the difference in blood pressure in millimeters mercury between preterms and controls. Anything above this line of 0 means the preterms have higher blood pressure. So for the whole cohort, the mean difference is 3.4 for systolic, 2.1 for diastolic. And when you break them down into men versus women, you can see here, unfortunately for us women, the women are disadvantaged. And I've just drawn that red 2 millimeter line to remind us that it's a clinically important difference, because for every 2 millimeter rise, you do get a jump in your morbidity. More recently, our group reported our 25-year outcomes for the Vix cohort, and that's in also the journal Hypertension just earlier this year. We saw 151 extreme preterm, extreme low birth weight adults and 119 term controls. Not only did they have clinic blood pressures, they also wore these horrific sort of ambulatory blood pressure monitors for a period of 24 hours. And you get your cuff pumped up every half an hour or so. And it's amazing how they manage to keep it on for 24 hours. So I have a lot of respect for them. We had similar measures at 18 and 25. And what did we find? Well, I just want to draw your attention firstly to the left. So this is nothing new. We reported higher blood pressure in the preterm compared with controls for not just when they were awake, asleep, 24 hours, systolic, diastolic, or mean. Everything is above 0. You can see here, all these dots are above 0, meaning they're higher. What is interesting and important is that they are all higher than the magic 2 millimeter difference line. So it is a worry. But what did we find additionally? Because we had measures at 18 and 25 years, we were able to see whether the difference between term controls and preterms increased or decreased or stayed the same over that 7 years. What did we find? Well, we found for the ambulatory blood pressure monitor, so this is the 24-hour blood pressure monitor, and that's supposed to be the gold standard, and also for a sleep, which is very, very sensitive to change. The worrying thing we found was that the rate of difference, so the rate of increase in blood pressure, your blood pressure normally increases with age anyway, it was greater in the preterms than the controls. So this is something that is new in terms of reporting. It is a little bit worrying, and I think we are duty-bound to understand whether this trend is persistent when these individuals get older. So it'll be good to see them again in their 30s. I know someone's raised their hand, but I would like to answer questions at the end, or else I worry we may run out of time. So I'll let Julie take note of the question. Finally, glucose tolerance, lipid profile. There are studies that have documented abnormal glucose tolerance with a glucose challenge. The actual prevalence of diabetes is not increased, but these guys aren't very old yet. Similar fasting glucose and insulin, and the data on lipid profiles is conflicting. So to summarize the cardiovascular outcomes, weight and body mass index catch up to term controls with age. They have higher blood pressure, and there is evidence to suggest that the difference is increasing as they get older. Glucose tolerance is abnormal. We don't know much about lipid profiles yet, but you're just wondering whether you are seeing a Barker's hypothesis playing out before our very eyes as these individuals get older, and will they be at risk of cardiovascular complications at an earlier age? I don't know, but I think it's a question worth thinking about. I'll move on to lung health now. Now we know that the preterm individuals are at risk of later lung compromise for a variety of reasons. They're exposed to a higher FiO2, they're ventilated, infection, inflammation, bronchopulmonary dysplasia. So all these risk factors that put them at risk for later lung compromise. And when people have done spirometry, which is formal lung function, what you can see is that people have consistently documented an obstructive pattern with lung function. So FEV1 is the forced expiratory volume in 1 second, and then the ratio to forced vital capacity, and the FEF 25 to 75. I don't have time to go into details about spirometry. It's something most of us would have learned in medical school or doing a respiratory term, but you'll just have to take my word for it that this represents an obstructive pattern, because the subsequent slides will report studies that have reported FEV1, FEF 25, and FVCs as outcomes. A little bit about lung development in health and disease, because it's important to understand what normally happens when we get older. So FEV1, think of this as a proxy of lung function. This curve here goes up, and you can see the age down below, okay? Lung function peaks, as do many other functions, in the early 20s. So I'm afraid I'm on this downward spiral now. But for those who have BPD, who always have a lower FEV1, they actually never quite reach the same peak lung function as a non-BPD individual. As I mentioned before, lung function decreases with age, normally, but we usually do not get symptoms at rest when the FEV1 drops to a certain critical point, because we might be dead before we get there, okay? So these are the sort of ages where you might get symptoms at rest, And what you do worry about when you look at the curve with BPD and preterms is they might get symptomatic at risk at a much earlier age than they would have otherwise. The decline with age is greater if you do nasty things to your lungs like smoke. So, heaven help us all, especially preterms if they smoke. So it's a very important lifestyle modification factor that has to be highlighted to those born preterm. Once again, the Vix Collaboration, they pulled all their data together from 11 studies to look at what lung function was like in late adolescence and early adulthood in those born very preterm, very low birth weight. 935 subjects, 722 controls. Published only last year in Lancet Respiratory Medicine. What did we find? Well, as per a lot of the individual studies, expiratory airflow was reduced in a pattern consistent with an obstructive airways pattern. But in this graph, what I have picked out from the article is participants with values less than the 5th percentile. So this is a clinically important disadvantage in your lung function. If you have values less than the 5th percentile, you will see here that the rates for very preterm, very low birth weight are all significantly higher than controls. And the odds ratios are very impressive, anywhere between 2 to 4.5. So they do have compromised lung function as a group, and it is very critical to look after themselves in terms of lifestyle modifications. What were the factors that were associated with better or worse lung function? You'll be very pleased to know that having antenatal corticosteroids was associated with a better FEV1. But if you were a male or had bronchopulmonary dysplasia in the newborn period, you had poorer airflows in adolescence and young adulthood. So to summarize the lung health in adult survivors of extreme preterm birth, they had worse expiratory airflows. They were not reaching their peak lung function even in their early 20s. And is this a sign that they're destined to have more chronic obstructive pulmonary disease at an earlier age than if they had been born at term? Once again, we don't know. We'll just have to follow them as they get older. So I'm going to move on now to mental health. Mental health is absolutely critical to all our well-being. It is very, very difficult to assess when a child is 2 years of age, but as they get older, we do have much, much better measures of mental health, and it is an important outcome in long-term outcome research. Now, a very recent, I think this has just come on press, this series of seminars just published this year with Sam Johnson and Neil Marlowe in the UK as co-authors. And this is a systematic review written by a group of people who are actually part of the Adults Born Preterm International Collaboration as well. And they looked at mental health outcomes of adults born very preterm, very low birth weight. They pulled data from 13 studies from the following countries that you see, outcomes anywhere between 29 to 35 years, and looked at the comparisons between very preterm, very low birth weight, and control. They looked at the following outcomes, 3 outcomes. One was whether the individuals had any mental health diagnosis as per ICD-10 or DSM-4. And then they probed into individual diagnoses, mood disorders, depression, bipolar, anxiety, and internalizing problems. All mental health diagnoses that are thought to be associated with prematurity. The results are mixed, and I think this is an important message. It just really depends on the cohort, the socio-demographics, and which part of the world they're in. But I think it's fair to say from this meta-analysis that they're not all destined to have a significant mental health diagnosis, and they're not all destined to have all these issues that are listed here. They did, however, find amongst the few studies that reported medication that there was an increased use of psychotropic medication in the preterm group compared with controls. Then I'd like to move on to transition to adult life. What does that encompass? Now, when we all transition from being a child to a school-age person to adolescent to then adult, these are the sort of things that are important to determine our ability to function effectively. Education, being able to live independently, form relationships with peers, have employment, let's not talk about it in the times of COVID, and also reproductive capacity. I'll just go through these 5 areas very briefly to summarize what's out there in the literature. So with education and employment, when people have looked at school completion, there are mixed reports. Some cohorts report a disadvantage, so less school completion in the preterm group. Others have reported similar rates. But what is consistent here is there seems to be a female advantage, so more women completing school than men. But of course, not surprisingly, it is related to socioeconomic class. In regards to employment, the message is a little bit more consistent. There's usually a higher rate of unemployment, lower net income, more individuals on social benefits. But for studies that have controlled for level of disability, some of these differences are partly explained by that. In regard to independent living, once again, the reports are mixed. But the general view is pointing towards the increased likelihood for extremely preterm adults in their 20s to still be living with parents. Now, we will all laugh at this because most of the studies are actually quite old. So we don't have more contemporary studies where there's been a shift, and certainly, you know, more young adults in their 20s are still at home with their parents, and that's not something that's that unusual. So I think we have to take the outcomes of these studies with a grain of salt because the society keeps changing with time. And finally, marriage and cohabitation, not many reports, but the reports that are out there seem to suggest that the lower proportion of extreme preterm adults in their 20s are either in a cohabitation status or married. Finally, with reproduction, there is some data to suggest that the reproductive capacity in those born extremely preterm is less than controls. And what about the risk of having a preterm child if they were preterms themselves? This seems to be more in the women who were born preterm rather than the men. And the rates are anywhere between sort of double that of controls. Why might this be the case? Like so many things in medicine, it is a combination of various factors: biology, physiology, psychosocial, nutritional, and economic factors. So risk-taking behavior. Now, this is an interesting aspect, and it's probably good news for the preterm parents. There's consistently reports that the extreme preterm group do undertake lower risk-taking behavior than controls. So less drugs and alcohol, less smoking, cigarettes or marijuana or other things that are around that you smoke, less delinquent behaviors, less contact with police, less incarceration in jail. So a good news story there. And some of the possible reasons that might explain this, well, there's usually more parental monitoring. Their personalities may render them less likely to undertake risk-taking behavior, and they may have less social opportunities because you know, they might be more introverted. And then finally, I would like to touch on quality of life. Quality of life can be measured by different questionnaires. And one of the commoner ones that people look at is something called health-related quality of life. So quality of life quality of life that you rate according to your health status. There are various validated questionnaires, as I talk about. The Health Utility Index Mark III, HUE3 is a popular one, as is SF36. So you might see these being used in studies that you read in the journal. And what these questionnaires allow, it allows an individual to weigh aspects of their health and provide a personal evaluation as to how they view quality of life. These results do complement our biomedical model of reporting functional limitations, you know, CP, disabilities, health aspects that I've covered thus far. But it's important to take note when you read the studies as to whether these questionnaires were reported by the individuals themselves, self-report, versus a proxy, family member, teacher, health professional. Because we do know that the results are different depending on who reports these health-related quality of life measures. So there are quite a few studies that have reported these outcomes in adulthood. I've just summarized a few of the bigger ones here. And you can see, I just want to point out to you, they've used SF36 and the HUE3 mostly. The age, usually in the 20s. Here are some teenage ones. There are more teenage studies, but I haven't included that in the talk today because of time constraints. I just wanted to take you through the results for these 5 studies. So the one from Norway, the health-related quality of life for the very low birth weights were poorer than controls. The Bavarian longitudinal study also found a very similar finding. But Brian Darlow's cohort from Christchurch in New Zealand found that they rated their quality of life to be equivalent to that of controls. So the results are a bit mixed depending on which part of the world you come from. But what I do want to highlight are these 2 studies by Saroj Sega. Those who know Saroj's work, you know, she's really the queen of long-term outcomes from McMaster in Canada. She has 2 publications here where she looked at the cohorts, firstly at 12 to 16 years, and then here at 3 time points. Same cohort, 3 ages. Now, the extreme low birth weight rated themselves to have a similar health-related quality of life to controls, even for those who had a disability. So they saw themselves as having a good quality of life despite whatever physical disabilities or intellectual disabilities they may have had. Note that this is direct. This is something that was reported by the individuals themselves. But when she looked at the indirect report, so this is reported by a proxy, the low birth weight individuals had a lower, poorer health-related quality of life compared with controls. So perspectives are very important. That's the one point I wanted to make from this slide. The second point I wanted to make from this slide is that despite following through into adulthood, there was no differential decline. So the disparity, the difference between terms and preterms remained similar as they got older. So they weren't getting worse. There was no definite improvement, but the difference was much the same. And it's really important to understand that. So I'd just like to summarize this section by saying that in general, health-related quality of life is rated well. There's no differential decline as they get older. And it does highlight this phenomenon called the disability paradox. So despite the functional limitations related to disability, individuals still rate their quality of life to be good. And this has been shown time and time again in different cohorts, and it needs to be respected. But once again, as I pointed out earlier, perspectives are critical. a patient perspective is critical for clinical decision making. You know, we throw around the term quality of life quite a lot, but do we actually understand what it means? And do we actually think about whether this is quality of life as per the individual or quality of life as per others, making a judgment on what the individual's quality of life is? It's very critical because the population's perspective will be important for allocation of health resources. So it's a balance between the two. So I know I've raced through the slides a bit, but I always tell Julie I can't concentrate for more than 40 minutes, so I don't expect anyone else to. So at the 41-minute mark, I just want to conclude my talk today by summarizing what we know about adult outcomes of those born preterm, extremely or very preterm. I've shown you data that is conclusive, that shows an increased biomedical challenge in terms of some cardiovascular risk aspects, their growth, their body composition, their blood pressure, and probably their glucose tolerance, their lung function. But when you look at their adult functioning and quality of life, they're probably doing pretty well. We haven't got the definitive answer in regards to mental health because the results are mixed depending on the cohorts. They might be at increased risk, but it's not clear-cut. But it's really important that there needs to now be moves to increase the awareness of the health risks faced by these individuals. We need to educate primary care and adult physicians about the importance of prematurity when taking a history of their patients. And we need to empower and encourage these extreme preterm individuals to adopt healthy lifestyle choices. I guess all of us need to do that, but it's even more important for these individuals given that they have these increased risks that potentially increases their health morbidities later in life. So long-term surveillance, of course, is a key. And finally, I'd really like to acknowledge the Vix group, all listed here, all the participating centers and our funding bodies. I have presented quite a bit of the work today, and I'm very happy to take questions. Thank you. Julie, I need help.
Hang on, yes.
Okay.
So, hi, oh, there we are. Thank you, Jeannie, you're wonderful. And if we could applaud you, we would, but we'll just rub elbows.
Okay, so Robert,
that was amazing.
Greetings. We should all acknowledge Bill Kitchen was an early driving force for Vix. Absolutely. So I didn't want to say too much initially because I was worried about time. The Victorian Infant Collaborative Study, I said, was started in the 70s. So it was started by a very wise man by the name of Bill Kitchen. He's a neonatologist at the Women's. He actually ran some of the very first trials of intensive care. And he recognized that because we were getting better at keeping the babies alive, it was important to understand the outcome. So he started Vix. Lex Doyle grew Vix. And now I'm trying to keep Vix alive. So Robert then says,
Robert again.
so I think, so that was Robert's first point. The next point was from someone by the name of Achilles Pad. In preterm neonates that suffered with osteopenia of prematurity, what would we need to monitor in growth and development of that baby? I didn't talk about bones. We need to monitor growth and development in all babies. That's good general pediatrics. In regards to osteopenia of prematurity, it just depends on how severe that they would have been. In Australia, where they do get sent home with supplements, we don't usually run blood tests. We don't usually do scans. We would monitor their general growth and development. What do we know later on? There is some suggestion that they might have a greater risk of osteopenia and osteoporosis in adult life, especially involving the femur. But we don't have large cohorts getting to an older age to understand the risk of pathological fractures in their 50s, 40s, 50s, and beyond yet. So that would be my response to Achilles pad. Then the next question comes from Robert again. The American Heart Association suggests intervening when diastolic blood pressure is 80 or higher. At what point would you start intervening when you discover? I'm not a cardiologist, Robert. So the answer to that is I do not know. The American Heart, but having done quite a bit of work with blood pressure lately, and in discussion with some of the pediatric cardiologists, there is some suggestion that the AHA recommendations might be too conservative and might be sort of, you know, recommending treatment at much lower levels than before. So that's under debate. All I can say about these young adults is they need to go and get their blood pressure checked. And if need be, then it should be the primary care physicians and in conjunction with specialist cardiologists determining whether they follow the AHA guidelines or they have a different set of cutoffs. At the moment, there's just one standard cutoff for everyone. There is no differential guideline for those born preterm. But the fact that hypertension are so interested, now hypertension is the official journal of the American Heart Association, and they are very, very interested in preterm work. You know, I think it's just watch this space. But for now, I think we've got enough data to be reminding these individuals to get their blood pressure checked and to reminding them to adopt healthy lifestyle options. Then I move on to Louise Macarius. Is there research that shows whether the increased BMI trend in preterm babies continues into adulthood? Yes. I haven't shown you outcomes from our 25-year study because that paper is actually currently under review. But when it gets published, I'll be very happy to share that with Julie, and Julie can send it to the team. So I haven't shown that data today because it's not yet published, but it's in that process. How should we follow them and support them beyond 2 to 3 years? Oh gosh, that's a million-dollar question. So from a clinical perspective, I think you have to think about a follow-up program that can be supported by whatever jurisdiction you live. It depends on what aspect of health you're looking for, and you know what you're looking for at different time points. So I don't have that luxury of time to talk about that today, and as I said, it will differ depending on where you live and what resources you have. But the critical message here is follow-up shouldn't stop at 3 years. There's more things that appear later on that we should at least, you know, provide them with support with. Then Louise, again, beyond 18, great, thanks. Of course, beyond 18. I mean, a lot of these health issues don't become obvious until they're older. But unlike, you know, the early follow-up programs where you get everyone back at 2 years and do their Bailey and see what the development is, see whether they're developing CP, I would think that as they get older, they need to be empowered to actually seek review themselves. I am not aware of any systematic national or regional follow-up program beyond adolescence for extreme preterm adults. But I think we are at that time now where we need to start thinking about how to get some of the messages out there. I mean, much as there are health concerns, what we don't want to take away from these individuals is the joy that they have survived intensive care. they have become these wonderful young adults. And despite the challenges that they either do face or will face, they still live these full lives. It's up to us to help them optimize it rather than to be so negative and say, oh, you're going to get this and you're going to get that, and you've got higher blood pressure, and you've got this and you've got that. So I think the message to them has really got to be one of optimism but with care. That's my approach anyway. I don't see any more questions.
So we have a few minutes, and I see Professor Satoshi Kusuda online from Japan. Is it possible to ask you to comment, Professor Kusuda, on how you, how long you follow up babies in the Japanese NICU community? Shall I unmute him?
I think you better unmute him.
Has he
I can't
gone?
hear him.
Yeah. Hang on. Is there anyone who wants to comment in the meantime? Or he may have run away. If anyone wants to comment in the meantime, please unmute yourself and or type a question on the chat line. Is there anyone else from Japan online? They have all run away. I saw them there before. There are no other comments from anyone? Okay, so I guess that's it. Jeannie, thank you so much. Irene says that's a great talk. This recording will be available when the cloud decides to convert it to an MP4 program, and I'll send around the link. If there are any other questions for Jeannie, is that okay to email you privately, Jeannie? Is that okay? She hasn't, I think she's muted. Anyway,
no, I'm not muted. I'm just typing it, Julie. That's my email address.
Wonderful.
Feel free to email me. I can sometimes be pretty slow with my responses. Don't take it personally, but I'll be more than happy to assist. And if certainly, there'll be many questions I can't answer, but I can point you toward in the direction where you might find an answer.
Okay, thank you so much, Jeannie. That was absolutely marvelous. So everyone, please stay safe. I shall end the recording now. Thank you. Bye. Oh, hang on. Before we run away, there's one last question from Singapore.
From Daisy.
Hi, Daisy.
Do we have longer follow-up for very low birth weight children have additional factors of being SGA2? Look, I think, Daisy, although the earlier cohorts were really by birth weight, I think in this day and age, it's looking at them in terms of their gestational age. Yes, there's some suggestion that they may have, a double hit if they are small for gestational age as well. But when you are actually looking at this extreme preterm group, those born less than 28 weeks, there are not that many who are really SGA for age, because if they were that growth restricted, they would not have survived. So I think the SGA group are really those who are more mature than 28 weeks. And yes, they may have slightly increased risk for certain sort of outcomes, even though the literature is not that definitive. Some will suggest that, oh yes, they have increased risk of developmental outcomes. There's not much out there about some of the other health outcomes that is that robust, because a lot of the earlier cohorts were selected by birth weight and therefore immediately would have included those more mature but more growth restricted. So a very different population. Whereas the more contemporary cohort since the 90s, really when you got good ultrasound and better gestational age aging, it's much clearer then. So back to your original comment, I think, look, if they're very low birth weight and very preterm, follow them up. Whether they're SGA or not, I would still give them that same level of care. I don't think there's enough at the moment to give them heightened level of care. But, you know, let's just watch and see what some of the other trials and cohort studies come up with. But certainly in Vix, we don't have a lot of SGA preterm, just because less than 28 weeks, you know, -2 standard deviations in your birth weight Z score, you probably wouldn't survive.
Okay, thank you.
Ta-da. See you, everyone. Bye. Bye.
Thanks so much, Jeannie. Stay safe. Bye.
Bye.
Bye.